Hey, welcome back to the Endo and Fertility Based channel. In today's video, I had the absolute pleasure of speaking with Dr. Naomi Whittaker. Dr. Naomi Whittaker is a board-certified restorative reproductive medicine physician and surgeon specializing in fertility and has received the focused practice designation in the minimally invasive gynecologic surgery by the American Board of Obstetrics and Gynecology. She's a 2013 graduate of Creighton University School of Medicine, Omaha, Nebraska. She completed a residency in obstetrics and gynecology at University of Illinois College of Medicine, Peoria in 2017, and is fellowship trained in medical and surgical naprotechnology by the Pope Paul Institute in Omaha, Nebraska. In today's video, we spoke about Dr. Naomi's refreshing perspective on hormone therapies for endometriosis patients, concerns over repeat surgeries for endometriosis patients, non-conventional yet effective management options for endo sufferers, and about the beauty of restorative reproductive medicine. Have a listen. Hi, Dr. Whittaker. Thank you so much for joining me.
Thanks for having me.
My pleasure, my pleasure. We've chatted before, and you're just such a wealth of knowledge, so I'm so excited to have you again chatting. So I have a short list of questions for you today. I thought it would be appropriate to just start off with a little introduction. Who are you? What do you specialize in? And why did you get into your area of expertise?
Sure. So I'm Naomi Whittaker. I uh, specialize in something called naprotechnology, which is a more narrowed focus under a broader umbrella called restorative reproductive medicine. And so I use my knowledge of women's health issues to treat the root cause and help women with health issues. And so this includes, PMS, PCOS, endometriosis, and infertility, which is just a combination of the above. And so I not only did OBGYN training, but I also did a fellowship, which focused on surgery and endocrinology or hormones. And so I'm able to approach both the hormonal aspects of women's health and what can go wrong and working cooperatively with the cycle to correct that, and also surgically correcting women's health issues, which certain women's health issues like endometriosis really can only be treated with surgery. And how did I get into it? Was the third part, right?
Yeah, like what
So
inspired you to get into this space? Is there any like personal health journey
absolutely.
link there?
Yeah. So as a medical student, my husband and I did start our family, and I had just a very standard cookie cutter approach to women's health. And I was less than impressed with that. And then I went to Creighton Medical School, and I was able to then do my OB/GYN rotation. And I again saw kind of very boring cookie cutter approach to women's health care. Just kind of band-aids here and there. And I thought, oh, that's kind of lame. That doesn't appeal to me. And I identified with patients in getting and not being super satisfied with that approach as well. So I got to see it from both sides, both as a patient, then as a provider and medical student. And I was not very impressed with how women's health was approached compared to other fields of medicine. I was doing all my rotations, and when you have chest pain, you do a heart cath, or when you have, but when you have pelvic pain, you get this pill. So later on in my OB/GYN rotation, I was able to rotate with these types of surgeons that do what I do. And that was super interesting to me, very appealing, really complicated, really looking at the complexity of hormones and the complexity of women's health issues in surgery, and doing such a beautiful job in surgery. And then these women were flying in from all over the world, including Poland, actually. Whereas that really stands out to you as a medical student in Omaha, Nebraska, that people are coming from all over the world. And these were the only surgeons that I worked with that had that. And so that really intrigued me and clearly showed that there was a lack of this type of care available. And so when I saw that, I thought, wow, I could really make a difference doing this.
Mm.
Yeah, it's going to be hard because I had a son at that time, and I was envisioning the future, and I was thinking, oh, well, I don't really want to commit my life to a very difficult field of being up all night, delivering babies and doing all that. So it's hard for me to finally agree to just really, even though everything in my being was wanting to do it, as far as I love the topics, I really fell in love with reading
Mhm.
the OBGYN textbooks, and I loved doing my rotations and the hands-on. Definitely took me some time to come to terms with that. But I thought, if I'm going to be away from him, I want to do something that I love. Like, I want to be able to come home knowing, you know, I was gone helping others in such a great way that it was worth it to be away from him. And so that's how I finally was like, okay, I can do this. How miserable would it be to be gone doing something like derm, even, I don't know, 3 days a week? And I wouldn't feel like I was changing lives. And here,
Mhm.
um, I can offer this amazing care and mother at work and as well, uh, through obstetrics and through helping women become mothers, which is such a passion of mine. And
Mhm.
so that just came full circle, and I'm just so happy that I ended up doing that.
Yeah, I've said it to you before that you are truly doing God's work. You share so many beautiful testimonials of like otherwise probably hopeless situations. And so it must be very, very rewarding for sure. I can see how grateful these people, these couples are that you share about in your on your social media pages. So yeah, beautiful, beautiful. You mentioned cookie cutter approaches. I think this is kind of like an appropriate segue. One of the main management strategies offered to women with endometriosis specifically are these hormone therapies, these hormonal suppressants, birth control. So I was curious about your position, your opinion as a surgeon, as a specialist in this space. What are your thoughts on this approach to endometriosis symptom management? Are there pros, cons? Just really anything that you're willing to share on that topic.
Yeah. Yeah. So it's not something that I integrate into my practice because I don't think
Mm,
it's good
interesting.
quality care. I see it as kind of a cop out, and probably why we have such bad surgeons getting
Mm,
away with bad surgery. So I
mm,
think it's actually big picture hurting women with endometriosis. If I see that a patient comes to me for a repeat surgery, for example, and she had a surgery and they put an IUD in at the same time, my question is, how do they gauge their surgery techniques and their outcomes? And does that mean that they don't trust their skills? For me, I I ask their symptoms before surgery. I see them for not only their post-op visit, but at 12 weeks, where they're more, complete healing is around 12 weeks. So at that 12-week visit, I want to see where they are. And really, I want to understand for myself their clinical picture. How well did the surgery work? And if it's not, and if there's still ongoing issues, what is it? Is it pelvic floor dysfunction? What is it, hormone issues? And so really understanding the disease is possible because I'm not suppressing these women. Now, Lupron, you know, is really harmful, I think, long term. Um, More so for women with endo too. They have all this chronic pain, and I've had endo advocates message me with their experience. They had all these years of pelvic pain. Now they're going to, perimenopause, and they have maybe bone mineral density issues now. And now they have new reasons for pain. And so these women are kind of sentenced to a lifetime of suffering from their endo. And that's the last thing we need, is a delay in surgery, then maybe a late surgery and a bad surgery, maybe Lupron for many years. And then, okay, now they get definitive therapy by removing all their pelvic organs. And then now they have repercussions for life. And so, it's just it's clearly a whole body condition. And so just putting that on, yes, it can get you through, let's say, a year if you can't get in and you have no other option. Absolutely, it can help with symptom management, but it's not my tool. It's not optimal. And it can help with pain management. But what I see oftentimes in more significant cases, especially, is the pain management of birth control, for example, wears off after a year
mm,
as their disease gets worse. And so I don't see it as an optimal choice. Is it an option? Absolutely. But um, it's not my preferred approach for many reasons.
mhm. Yeah, and I was reading an article that you were featured in as well in preparation for a chat, and there was I don't know if it was your quote specifically because I think there were a few experts quoted in the article, but talking about like the nutrient deficiencies that come with use of hormonal birth control. That's another thing to consider. A lot of those vitamins and mineral deficiencies are very relevant for endometriosis disease progression, energy, for nervous system support, for the way that we eliminate hormone and things like that. So, yeah, lots of things to consider.
Folic acid for women who want to conceive. We're depleting them before they're trying to conceive.
Yeah, exactly. Yeah, I think you were the first person on socials or first specialist that I also saw refer to the effects on suppression on the visibility of lesions when going in to perform surgery. Could you speak to that at all? I don't know if there's much to add there, but my understanding
Yeah,
is
we don't.
it's harder to see.
I mean, it makes sense. It's hard to prove that, but I have women off of it for 3 months before, if they come to me from with a prescription for birth control and they're coming from elsewhere, for example, I have as a requirement that they're off of that for 3 months to make sure that we can see the lesion as clearly as possible. It's very possible that it will alter the appearance and lead to a less successful surgery if we're not able to see it all.
Yeah, that's definitely something that's worth considering if somebody is watching and considering surgery and is currently using these suppressants.
The evidence I have to support that from my clinical practice is that sometimes I go in for a diagnostic surgery for very advanced cases and I bring them back for another surgery. And I won't see the same lesions both times based on
Mhm.
where they are in their cycle. So that's another benefit to sometimes, in extreme cases, doing more than one, a diagnostic and a robot separately.
Mhm.
For example, I had a teenager and she had endometriosis on her tube.
Mhm.
And I saw it at the diagnostic, and she was in a different time in her cycle, and I did not see it at the robot, but I knew where it was. I had I had made notes, and I excised that area of the tube, and it came back positive.
Wow, interesting. So just so I understand you correctly, is there are differences in the visibility of the lesions even just based on like cyclical changes? And
That's my experience.
oh
Yes,
wow, fascinating. Okay. So when are they more visible? Is there like a
I'm not
hard to
sure.
say?
Theoretically, I think probably around ovulation would be
Okay.
ideal when
Uh,
estrogen's the highest.
Right.
Theoretically,
Yeah, interesting. Fascinating.
I need to pay more attention to that.
Oh my goodness, I'm sure there are a lot of findings on a regular basis that you're making or connections that you're trying to make, but very fascinating. Is there ever a scenario in practice where you're using birth control or hormonal suppressants? Never. Okay, interesting.
Not really. I guess, I mean, I've used Lupron once for a woman. She was in a very difficult social situation and she was perimenopausal. So it
Okay.
was more of a very unique situation. And I guess they're very unique situations.
Yeah,
So again, it's more of the uh, exception, rare
interesting.
exception.
Fascinating. I think that would be very surprising for a lot of people watching to hear. So it's very interesting.
Yeah, you
I,
can use bioidentical hormones in a very similar way with a similar outcome. So
yeah,
it's not that I'm saying, oh, you can't have that. Well, this is my option that I feel like is healthier for you. And I think it has better outcomes, not only for pain, but for, whole body health, which, you're more than your uterus, you're more than your pelvis, especially
right.
with endo, but in women's health, you're your breasts, you're your brain, you're your bones. And
Hmm.
so looking at you as a whole person and not just your uterus, using bioidentical therapy makes more sense to me.
Yeah, and this is what I wanted to chat about with you next is, are there other supportive, kind of more, I don't know if natural is the appropriate word to use, but strategies that actually work with your cycle that are maybe a little bit more holistic, natural. I personally use both low dose naltrexone and bioidentical progesterone because I do have a NAPRO doctor who supports me. And I have noticed massive improvements. Like low dose naltrexone took me from day one of my cycle, vomiting, fainting, passing out from pain to my period coming on very, very gentle. And then progesterone has made a massive difference in level of pain, in some like spotting symptoms, as well as like the heaviness of my bleeding. So Yeah, I'd love your thoughts on how those are used, how they can be helpful. I mean, I don't know if I just answered my own question.
Hey,
What kind of improvements do you see in your patients using these therapies?
that's very common, what you're describing.
Yeah.
Naltrexone helps with endorphin deficiency, which affects mood, energy, inflammation, immune system dysfunction. And so you would approach, those issues with endo, with LDN. Um, Bioidentical progesterone is anti-inflammatory, helps oppose estrogen, and so you don't see as much thickening of the lining of the uterus. You also see protection of the breast tissue. You see an improvement in PMS, both by LDN and progesterone. Um, and, we often see progesterone deficiency in women with endometriosis as well.
Hmm.
And so it can help with bleeding, pain, cycle regularity, abnormal bleeding. The thing is, it's more difficult to use because you have to understand the menstrual cycle to be able to test the hormones, target treatment, and have the patient understand when to optimally give it. And so that's likely why it's not well used. It's not that it's not effective. It's not that it isn't scientific. It's not studied because we're so far from advances in research that we would actually use a cycle chart. I'm hoping to, I'm starting a research project with Sarah Hill to hopefully at least even understand the basic correlation of symptoms and the cycle chart with the
Hmm.
PMS. So that's extremely foundational. No one has done it. I mean, that is very basic. And so what we're doing is much more than that, much further removed. It's not researched enough or at all, really, unfortunately. But as you have said, that's a very common experience.
Yeah. And can be so helpful for women with endo because it doesn't come with all of the unpleasant side effects. It's still supporting your natural cycle and is absolutely effective in my experience. I know that that's just my experience, but and you did speak to why this is not as accessible as it should be. Is there anything that we can do to, is there anything I can do, for example, as a dietitian supporting patients to help them access these therapies? Like I have written letters on behalf of my patients. I've linked to whatever research I can find. Is there anything, I don't know if this is even a fair question, but I think you can think of that would be helpful to support more women in accessing these therapies if their doctors are not familiar with them?
Yeah, I mean, I think knowledge is power and trying to understand your cycle as best as you can. I like the crate model system. And then you work with a fertility care practitioner, which is a teacher of the crate model system, to understand your cycle, see issues with that. And that way you can advocate for well, see things that suggest certain issues because we can see a lot of issues just based on that data. So that you can advocate for yourself and find a provider that's supportive and getting multiple opinions, really seeking different perspectives. It would be nearly impossible to get cyclical bioidentical progesterone from any your local neighborhood OBGYN. I mean, you could try. There are some that are more open-minded, and Prometrium is available through prescription at any standard pharmacy. And so being that, thank goodness, is out on the market. And so you can advocate to get that. They won't likely be trained on how to test or levels or when, but the more you kind of educate yourself through information that's out there, hopefully you can kind of figure out a way to make it work. But it's very difficult.
Yeah, it's unfortunate. Maybe in time they'll become more and more accessible, I hope.
I hope so too.
So I do want to kind of switch gears a little bit. I was listening to a really fascinating interview you did. I mean, you've done so many interviews and so many podcast recordings, but all about like scar tissue. And I've connected with so many women that are going on their third, fourth, fifth, seventh surgery. So I wanted to ask you about your thoughts about recurring surgeries for endometriosis. You know, anything uh, of value, I guess, to share there. I don't know if that's too broad of a question.
Oh, I mean, I have a whole series that goes deep onto when to consider repeat endometriosis surgery. But yeah, one of the problems is scar tissue. So even with a very thorough excision surgery by a very top tier surgeon, we are concerned about adhesions. And adhesions in many ways are worse than endometriosis because once they form, they like to reform and can make the surgery very complicated and increase risk of complications. Really, adhesion prevention is key, and no one's really talking about it because it's there's not a lot of research. There's definitely data to support things that I do, for example, but gentle tissue handling, keeping the area nice and clean of blood. I use the laser, which is a very gentle, very accurate instrument that doesn't cause a lot of burning of healthy tissue. So it's a clean cut, similar to a scalpel. Also, ovarian suspension. I leave fluid at the end of the procedure, and I want to make sure it's clear. And then for very severe cases where I'm afraid everything's going to freeze back together, if that's how I found it, again, the adhesions were there, they're going to want to reform. Any raw area is going to want to stick to another organ because they're just sitting up next to each other. I leave the fluid to help them kind of be apart. And then I have a Gore-Tex membrane as an option for very severe cases. For example, women that were told you need a hysterectomy and they're trying to conceive, I'd put a Gore-Tex in. And so that Gore-Tex is like a raincoat, slippery barrier, and it does need to come out in 7 to 10 days. The more things I stack on top of each other for adhesion prevention, so hydroflotation with the fluid, ovarian suspension, Gore-Tex, of course, the more complicated the disease, the more I stack adhesion prevention measures for that woman. We can really get adhesions to a minimum. Now it adds a lot of time to the procedure. And I sew defects closed of the ovaries, of the uterus, of the peritoneum, the skin, and the abdomen. And almost no one is doing that because it is time consuming and there's no reimbursement for it. So again, we don't get reimbursed for preventative medicine, and that counts for surgery as well, right? So, but what I find, I don't have many that come back for repeat, but sometimes we do. Ongoing infertility at 18 months, a recurrence of an endometrioma. I just had one recently. She had a 14-centimeter endometrioma. Well, I want to say 4 or 5 years ago. I'd have to look back. And her pain has still been great. She's managed with diet, progesterone. She loves her progesterone so much. And she had a recurrence of a couple small endometriomas that we found on ultrasound from our regular just monitoring. And so I booked her for a case, and typically for these women I say I expect your disease to be a lot better or minimal endo, or and I'm hoping for not much as far as adhesions because it was me in there. I'm glad it was me. So that's exactly what happened. Usually some mild adhesions between the ovaries and the uterus are there, and sometimes some mild disease behind the uterus. And so it was a much easier surgery this time around for me, for her. And I'm hoping this will be your final one. Again, she's more of a very advanced case. And we were doing ovarian preservation too, to keep her from the risks of removing ovaries, which is earlier death. So, endo is obviously a terrible disease, but she did so well. And the surgery was so smooth and so much easier than last time. So if you're having repeat surgeries and you do adhesion prevention and you're very thorough, hopefully you don't need a repeat surgery. But if you do, it should get better each time. And so it shouldn't be more adhesions each time, more disease, if it's done well.
I don't know if you have a statistic. I was just curious, or just like general information, but with your type of approach versus sort of, I don't even know what to call it, the standard, the non-NAPRO restorative reproductive medicine approach, what is recurrence like comparatively? Is it significantly lower, or is it comparable to kind of the standard
Endometriosis or adhesions?
Of endometriosis?
Yeah, I don't have a NAPRO specific statistics, but I did look ablation versus really good thorough excision. I try to look at different studies that would compare those two. Endometriosis recurrence. Of course, ablation is 60+%. I mean, it's really 100, right? Because it's probably there. Now, are symptoms managed maybe with ablation? Sure. So 60+ versus 0 to 25% with proper excision.
Wow. Very
Dr.
low.
Patrick Young, who has very similar approaches to what I do, he's in St. Louis. He did a study on teenagers. So early intervention and thorough excision, you can have 0% recurrence. Again, early, so it's usually earlier stage disease, expert excision, you could have near 0% recurrence. 25% recurrence is excision with endometriomas. So most people are somewhere in between.
Yeah, I saw that study. I referenced that study in the video I did on excision surgery. That was really cool. 0% recurrence. That's
It's
amazing.
unbelievable. I did not think that would be possible.
Yeah,
But
amazing.
I love teenage patients. I know that most OBGYNs run away from them, but they have very unique, specific appearance of disease. It's usually pretty easy, quick. They
Hmm.
feel so much better, and you reduce their risk of infertility. And now they have 30 plus years that they're going to hopefully feel better. I
Yeah.
mean, so much for so little, and from my end.
Yeah, that's amazing. Yeah, good point. For sure. I mean, especially with the fertility preservation piece in young people. In the beginning of our chat, in your intro, you mentioned restorative reproductive medicine. Uh, could you share a little bit about what that is specifically, and then if there are any like specific examples of how you use this approach to support women with endometriosis, whether it's in fertility, restoring fertility, or in relieving pain related to endo? I know you do a lot of cool uh, tube clearing or unblocking procedures, which is so fascinating because I connect with so many women who
Mhm.
have blocked tubes, and it's heartbreaking because, I mean, it's just heartbreaking. What else can I
It's
say?
heartbreaking because no one's correcting tubes.
Right.
No one is trained how to correct tubal problems. Nobody, almost
Except for
nobody.
you.
Well, there's like a few people. You can find interventional radiologists and some OBGYNs, but they are so few and far between.
Mm,
Yeah. So restorative medicine is the opposite of suppressive medicine, right? Where we're going around the issue, overriding the body's functions with birth control or IVF, for example. And so restoring health is correcting the problem through removing endometriosis or cooperative hormone therapy, tubal corrective surgery instead of IVF, for example. And so, we find a lot of health issues when we're looking to root cause medicines. So, women with infertility or pain, I've found cancers and
well,
accidentally cured them of cancers. I just published that with AAGL. And so, overriding these issues has consequences as well. Not only are these other therapies problematic in the short and long term for symptoms and complications, but we're going to ignore and overlook red flags that there are serious health issues. We find multiple cancers a year in our practice. We're pretty high volume, so it's very low,
oh,
1 to 3 cases, I would say, of cancer a year that we find in young women.
wow.
And so, the case series that I presented is just 4 women in 6 months that it was just a really bad time. It just happened to happen.
Mm,
This was very a fluke thing. But one had stage 4 appendiceal cancer, and she's
wow.
cured to this day, and she's 3 years in remission. And yeah, we were able to find it. Otherwise, she would have no idea. And she's cured. And a lot of these, when I send them to specialists. That's clearly not my thing. They'll say, go back, because whatever she did, she was very thorough. Multiple specialists have told my patients that. And that's not about me. That's not anything that is special, unique to me. Like, it's not complicated. It's just the way I was trained. The systematic mapping of the abdomen and pelvis technique and near contact laparoscopy. That means zooming into the pelvis. So
Mm.
I follow a map, the same map every single time. It's a standardized approach, reproducible. I won't forget to look anywhere. And then near contact. So not only do I look at big picture, but I zoom in really close to find even near microscopic disease.
Yeah, because endometriosis can be hard to see, right? Especially if it's like very, very small.
Yeah, it can be small, it can be clear, it can be these little dot lesions. And then you can have its sister endosalpingiosis, which is even more subtle a version of it.
Wow. So it sounds like some ways that the restorative reproductive medicine approach helps is well, you mentioned the basically curing people of cancer, so identifying it before I suppose there are any like signs or like
Correct.
signs that are directly related to cancer, clearing the tubes, supporting the cycles with complementary or cooperative hormones. What about endometriomas? Is it just like removal, or is there anything specific to endometriomas?
Yeah, my cocktail is removing the endometriomas. I know women have been with IVF doctors, they have instilled a lot of fear in endometrioma removal, but really, unfortunately, the damage has been done and
Mhm.
it's important to get that disease out. If you throw medication like IVF at it, you're going to grow them. You could
Mhm.
cause them to rupture and cause them to cause more scarring. Once the ovaries scar to the bowel and uterus, the risk of medical complications are very high. So I think it's dangerous to do anything other than removal. Yes, there is a risk of menopause or ovarian reserve, which is technically already there with endometrioma, unfortunately.
Mhm. Mhm.
The only hope of salvaging that ovary, in my opinion, is removing the disease very carefully, using a laser if needed, but really trying not to use any energy, doing minimal damage to the ovary, shelling the cyst wall out, getting it out, reconstructing the ovary, maybe doing PRP for surgery and adhesion prevention. All of those things are very important surgical. Other things I do to help support ovarian function, check DHEA, and I like to optimize it over 150,
Mhm.
cooperative hormone support therapy, N-acetylcysteine, usually 600 milligrams 3 times a day for 4 days a week, and bioidentical progesterone. That whole big picture, um, we see a good response. Obviously, the disease itself can really damage ovarian reserve. And I think earlier intervention, not stimulating with high dose estrogen through like IVF,
Mhm.
um, especially not, or IUI even, especially not puncturing the ovaries and trying to retrieve eggs. That completely spreads the disease
Mhm.
potentially. At least, of course, anecdotally, and it's super hard to prove, and there's no financial incentive to research that. But from cases I've gotten, they report worsening of symptoms after IUI, IVF, and they have some of the worst pelvises I've ever seen. Um, yeah.
I do want to kind of end that thought with a positive note, though. I'm assuming you're still seeing a lot of positive outcomes, positive fertility
Overwhelmingly,
outcomes.
overwhelmingly, I honestly have had one patient have menopause, and she was like in her late mid 40s, so she was already on the brink.
Yeah.
Overwhelmingly, I see things improve after endometrioma removal.
Yeah.
Every ovulation, hormones. Yes, I had someone send me her story. Her AMH went down for a little bit, went back up, though AMH is not a good test. But,
Mhm.
anecdote, I know people really think about AMH. So, yeah, and your body takes time to heal. Overwhelmingly, I save the ovaries. They function. That woman with the 14 centimeter endometrioma that I did a repeat surgery on, both her ovaries look beautiful. Um, so overwhelmingly, endometriomas are not this death sentence for your ovaries. Not when done well. Again, you need to remove all of the disease and be very delicate and really value that ovary, right? Really be an advocate of that ovary when you're in the OR. Really just trying to save as much of it as you can. That's really important. And putting it back together in a beautiful way. And that includes sewing it closed by rolling the edges in similar to the hem of pants. You
Oh,
want it to be
interesting.
nice and smooth because if any edge is raw and everted, that is going to be a risk for scarring.
Yeah. Yeah.
So yeah, not many surgeons are even doing that. Some surgeons don't even close the ovaries. I don't understand how. I don't understand. I guess they think it's just going to go back together, and it could, but it's better in any circum as much as you can to guide the tissue because it
Mhm.
doesn't really know what to do.
Mhm.
For healing, it's just going to send all these, you know, inflammatory chemicals to kind of help it heal, but it's not going to know what to put
How
back
to do
together.
that best. Yeah. Yeah.
Yeah.
Okay, so I guess my two last little quick things. One, how accessible is NAPRO tech or restorative reproductive medicine, let's say in like North America, is it relatively accessible? How many Dr. Naomi Whittakers are there out there?
Yeah,
Not
it
an
depends on what
exact
you need.
number.
Depends on what you need. If you need surgery by a fellowship trained surgeon, there's very few of
Okay.
us. If you have someone who uses NAPRO principles in surgery, there's even more. I know for the fellowship, it's only about 30 of us,
Wow.
maybe
Okay.
practicing. Um, are there other surgeons though that use these techniques? Absolutely. That do NAPRO, that didn't do the fellowship, or that are REIs specializing in fertility surgery. There are some that use these techniques. There's an anti-adhesion surgeon in Georgia. He wants to use Gore-Tex, he can't, but
Mm,
there are people that do these things. It's hard to find someone that does them all in one. Like I'll do the tube study, open the tubes, check for endo, check for endometritis all in one surgery. So what I find is if women are educated about what a good endosurgeon is like and what kind of tube study is best that can correct things, they might go. I had one go to a surgeon, a really good endosurgeon, get really good success with that, and then went to another surgeon to get the tubal surgery. So
mm,
you can piece these things together. It may not be as easy for some as like my patients, for example, but it's still possible to get this type of care and advocate for it. That's why I made that a course on how to screen your surgeon
oh,
so that you know what I do to get it all in one, and you can screen your physicians and advocate for yourself and find a surgeon similar to me because I can't treat everyone. I have a long wait list too,
mhm.
and there are only a few of us. I'm hoping this becomes more common. All of these become, it's just good quality medicine based on research
Yeah.
that has good outcomes to support natural fertility, right? So, unfortunately, a lot of endosurgeons that are really skilled, they see, oh, I have IVF as a backup, so someone may not need her tubes or she may not need aggressive adhesion prevention. But really, this type of medicine is good care, and I hope it just becomes more valued, with more surgeons. And I hope with time it will, with more awareness.
Hmm. Yeah, I hope so too. Okay, I guess just to conclude, did you have any final thoughts, maybe for any women with endometriosis who are listening, who are trying to conceive or who are in a lot of pain from day to day? Just any words of encouragement or any like final thoughts? I know it's a bit of a broad question.
Yeah. I mean, I would say the fact that you have endometriosis is huge, or have a high suspicion. You're way ahead of everyone else, right? Like, for example, I didn't know I had endo until I became an endosurgeon. That's how I figured it out myself after decades. Even in my OB/GYN residency, it's just so ironic. It's just so exemplative of the problem of women's healthcare. Had no idea, and I'm in the middle of the thick of it in training. But understanding endo, understanding you may have a high level of suspicion, and you are your best advocate though too. There's no one should put their whole trust in me or anyone. You are your best advocate
Mhm.
for your care, and so reading about it and really understanding it, and being an advocate for yourself and never feeling like not at peace when you make a decision with a surgeon or with a medical treatment plan. um, yeah, and there's a lot of options out there and hope. It takes time.
Yeah, beautiful. I will link to the course that you mentioned in the show notes in case anybody is interested in that, because that sounds very valuable, right? Being able to screen um, based on Dr. Naomi Whittaker's standards for your surgeon. So we'll put
Yeah.
it in the show notes. Awesome. Well, I don't want to take much more of your time on this Saturday. I really appreciate you. God bless you for your time and all your knowledge and everything that you share. So just thank you
Thank
so
you
much.
for that wonderful. I mean, it means a lot that you know so much, and you did even listen to some other, interviews to be able to kind of know where to go with this. So that's very nice of you. Thank you.
Yeah, I have a couple that I didn't get to listening to yesterday that I will. And I can also even link those in the show notes for anybody watching if they wanted to listen to some other interviews that you've done. But I mean, you're a surgeon. I mean, I'm not a surgeon. I don't work with the types of scenarios, people, problems that you do. So I'm not going to pretend that I know much about that. But it was really fascinating to listen to some of the other interviews and to have this chat with you today. It was really insightful. And I hope that others who watch this video learn quite a bit too. And like I said, I'll link to the other interviews to the course. So hopefully we can get more people continuing to learn and know about this approach and know that it exists, because it's incredible. It's truly mind-boggling to me that this exists. And I would love as many women to be able to access the support as possible. So we'll do what we can to get the information out.
Exactly. That's all we can do. I think it's so hard to convince physicians to do anything different, right? Especially once they're in practice. So hopefully we can inspire patients to advocate for themselves, to maybe change a couple doctors' minds. I think it'll come from the patients and self-advocacy. And then there's future generations of medical students listening to this. And so hopefully, so hopefully these future medical students can be inspired to do better. And maybe it'll draw people that want to make change into the field instead of running away from it. Yeah. Because that's kind of what we're taught in medical schools. You go to where you feel drawn, like where you fit in. Well, I went in with the opposite. I want to go in and do something different. I want to stir things up. So, yeah, it's a little daunting when you're young and in debt, but through God, all things are possible. And so I was like, okay, Lord, I'm going to just trust you.
Absolutely.
He, set me and my husband's super strong, and I lean on him a lot in the bad times. I lean on God a lot, and he finds a way. He gives you what you need when you need it. It's
100%.
Yeah. So thanks for being part of it and what you do. And I don't do dietary stuff. So so we're going to complement.
Yeah, we can help each other out.
Yeah. The cool perspective I have is I get to go in these pelvises, right? And like I have the 3-tier endo self-survey too.
Yes, I saw that.
That I made. Yeah. So have you looked at it? The symptoms on there and stuff?
I have looked at it because I think you put it out a while ago, right? It's not series. Mm-hmm. I looked at it then. I don't have a up-to-date recollection of what's on there.
Yeah. I'd just be curious your thoughts or feedback.
Yeah.
It's just my brain. It's just my brain on paper. It's not scientific. I use it because I just, over many surgical consults, I do the surgical consult, hear their symptoms, kind of fixate on certain red flags, and then I do surgery, and it helps me predict if there's endo or not, which overwhelmingly it is with those symptoms.
Probably some degree of accuracy to that, I would imagine.
Yeah.
I'll take a look at it for sure, and I'll let you know.
Yeah. I would love to study that. I've formally been giving it to my patients, and I score them before surgery. So I could do a study on it. It's just me though, and my nurses, and yeah.
Well, let me know if I can help at all. But
okay.
Yeah, I hear you. I know you're trying to accomplish so many things.
Yeah, and I'm like, over here, I want to do this. And I get over here, no, I want to do this.
Yeah.
And then, social media is nice because it's kind of a quick fix. Like, you see your results, you see people, oh, this helped me, or I found a surgeon because of you, and I'm pregnant, So it's hard to do the research that you don't see results for years.
Yeah, I know.
Not as,
I can imagine. Yeah. Well, keep up the excellent work. Like I said, I know you're changing lives. You're doing God's work. Thank you so much.
God, I'm telling you.
I feel the same way. When somebody, I was just connecting with a patient of mine that I had yesterday. We had a conversation. Extremely advanced endometriosis. She did pursue IVF for her first son, and through our work together, she was able to conceive naturally. And anytime that happens, I always say it's all God. Like, it's not me. It's just God's working through me. And I don't even know if what I'm doing is what resulted in the pregnancy, but she's doing really well. She had her first ultrasound, and just praise God for that.
That's amazing. Oh my gosh. Yeah, I know. It's between God and the couple, and we're just a little tool over here to help them out. That's what I say. We're not. Exactly. Well, thank you for this opportunity, and I hope this is helpful for you.
Yeah, I think it will be a very popular video, and like I said, we'll share it across all the platforms. And thank you so much for your time. God bless. Good luck with baby.
Thank you. God bless. Thank you.
Thank you so much for watching today's video. If you haven't already, please like this video and subscribe to my channel, and I'll see you in the next video.